introduction. So it is my pleasure and privilege to be talking to you about a very interesting topic on insulin. So our title is Finding the Sweet Spot in the Current Landscape of Basal Insulin Therapy. So this is my disclosure. This is a CME grant from Sanofi Aventis. I also do lectures for other diabetes-related pharmaceuticals. So patients living with type 2 diabetes are still struggling to achieve glycemic control. And in fact, despite the understanding of the need for insulin and its stepwise intensifications, patients have been shown to have poor glycemic control for more than 7 years before they are even started on insulin. And most of them are started when their HbA1c is more than 9%. And because of this, it unnecessarily exposes them to the diabetes-related complications, both micro and macrovascular. And several large prospective studies have also shown that even these patients already on insulin, a lot of them still struggle to achieve glycemic control. So as many as 30 to 50% of these patients with type 2 diabetes may remain above their glycemic targets 6 months after starting basal insulin. So why? Let us look into the data why this is the case. So this is a survey conducted among type 2 diabetic patients who are already on oral anti-diabetic drug. As you can see, a lot of them, about 46%, would still avoid insulin. And the data from PETRAC in 2013, 82% still opted to avoid insulin therapy and continue their oral anti-diabetic treatment despite failure of these oral medications. And the study by Khan in 2008 have shown that even those already who have undergone repeated counseling, 28% of them still refused insulin therapy. So this is a study conducted to look at how common this delay to initiate insulin therapy happens. No? So in 3,295 patients who are insulin naive, who were recommended to start on insulin therapy, 29.9% of them, or 984, declined. And of this 984 who declined, 374 or 30% of them eventually opted to start insulin. And it took them about 790 days from the time they were supposed to be on insulin before they are finally initiated on it. And this is a real world study looking at the treatment persistence, no? How many of these patients can sustain insulin treatment. And as you can see, whether they be on detemir, pen, or glargine by pen, or glargine by vial and syringe, most of them eventually discontinue insulin treatment after a year. So at the end, about 50% of them are no longer under insulin treatment. So what are the contributors to this? First, number one is the patient's perspective on insulin. So they have a lot of things that they worry about when they are on insulin. One of which is concern about the side effects of this insulin. They're concerned about hypoglycemia when the risks and the benefits are not explained properly. But as you can see here, insulin therapy, which wherein self-care training is provided, you achieve about 100% probability of being able to be successful in initiating your insulin therapy. So, key contributor to two, or the second, is the perceived treatment burden. So these are the factors that significantly is associated with the frequency of insulin injection omission or even stopping their insulin. Primarily is the frequency of insulin injection. The more often you make them inject, the probability of them missing this injection is high. Injection embarrassment, no? In this age and time, nahihiya pa din sila. They don't like the idea of them being on insulin. It is perceived to be a negative impact, or people perceive that they are getting worse, malala na sila, malapit na silang mamatay, no? So, third is interference with activity of daily living. So, umiikot ang buhay nila dun sa time that they have to inject their insulin. So they plan their daily activities around their insulin injection. Pagkagising pa lang sa umaga, nag-iisip na sila, magtuturok na ako, umaga ba, hapon. So all this, and of course the pain of the insulin injection, are treatment burdens that make our patient miss or stop their insulin injection. So this contributes to poor adherence. So effective strategies, no, are needed to overcome this challenge. We need to help our patients overcome this perception and burden perceived by them or their caregivers. So let us look at the solution. First and foremost is effective communication. So here you can see in this internet survey done among more than 590 adults with type 2 diabetes in 7 countries, and they reported the perceived helpfulness of the healthcare professionals like us in improving their insulin behavior. So as you can see here, beneficial would be when we explain the benefits of the insulin, when it is a collaborative type of administration. We educate them, we empower them, no? And when you dispel, you tell them the truth about insulin, that being on insulin doesn't mean that they are dying or they are worse than those who are not insulin. It's just that insulin is part and parcel of type 2 diabetes treatment because of its progressive nature. Personally, I tell these patients of mine at the onset, even if they are just on tablet, that eventually, because diabetes is a progressive disease, we will need insulin as part of their treatment. So we don't use it as a form of punishment or a threat, but it's just part of the treatment that the patients may have to undergo. So this effective communication and collaboration between us, the healthcare providers, and the people with diabetes, by providing them self-management and support and education, will be a very effective tool of communication. So let us look at the therapeutic inertia of basal insulin therapy. So these are the different factors contributing to the delay of the starting insulin treatment. So it's multifactorial: healthcare, the patient, and system-related. For the healthcare professionals, it is the reluctance, no, on our part to initiate and titrate insulin aggressively. One reason would be it's burdensome. It takes a lot of time in our clinic explaining to our patients this treatment regimen. Also, the fear of hypoglycemia for most physicians is also a deterrent or contributes to this therapeutic inertia. With regards to the patient, I have mentioned a while ago, the fears contributing to them wanting to be on insulin are one is being unaware for the need of insulin as part of their treatment. fear of weight gain, depression, anxiety, limited motivation, lack of perceived efficacy, no? And most common also would be the concern about the impact of this insulin on their daily life. There is also a thing which we call the system related, no, to this therapeutic inertia, and that is the lack of time, resources, and education of our patients. So this various therapeutic inertia can either be initiation inertia, yung patients hindi na uumpisahan ng insulin on time even if they already need it. Titration inertia. You started your insulin and yet you failed to titrate to achieve the goal of your insulinization. And third is the intensification inertia. Intensification will be adding either a prandial insulin or additional anti-hyperglycemic drugs. So what are the recommendations to reduce this therapeutic inertia? One is to see patients regularly. Every 3 to 6 months, we have to reevaluate our anti-hyperglycemic regimen. And we have to monitor metabolic variables and cardiovascular risk factors like HbA1c. Their patient's self-monitoring of blood glucose must be evaluated and must be reported to you. Patient's weight, blood pressure, and lipids. So self-management education programs must also be done regularly. And support of our patient's emotional being and the use of a regular self-titration of your basal insulin with an evidence-based titration algorithm. So when we start them on insulin, we already advise them on how to do self-titration of your basal insulin to achieve your agreed goal of glycemic level or your fasting plasma glucose target. This is very important because the main goal of your insulinization is to achieve glycemic control, because failure to do so can lead to micro and macrovascular complications like risk of blindness, end-stage renal disease, cardiovascular disease, and lower limb amputations. And it has been shown that despite technological and therapeutic advances that we have now, many adults with type 2 diabetes still fail to achieve and reach HbA1c targets. So we have to understand that type 2 diabetes, as I've mentioned, is a progressive disease, and many people require treatment intensification with insulin therapy. And this insulin initiation should be followed by intensification or titration and intensification to achieve glycemic control. Now, what do we mean when we say titration period? Now, let us talk about insulin dose titration and titration period. What does it mean? So, this is actually the phase we're in, defined in many trials as the first 8 to 12 weeks of treatment. Now, when we start our insulin and the time when we are titrating the dose to achieve our target goal. So, the insulin dose titration with insulin glargine, as seen in a pooled analysis of 15 treat to target studies of glargine 100 initiation among insulin-naive people with diabetes, showed that 89% of the overall increase in the basal insulin dose is actually happening in the first 12 weeks of treatment. And the guideline recommendations, once the basal insulin therapy is initiated at 10 units per day, or you can either initiate it at 0.1 to 0.2 units kilogram per day. Titration is performed every 3 days to reach the suitable fasting plasma target. So, personally, I make them monitor every 3 days or twice a week, and then I make them increase the dose by 2 to 4 units, but you can go just 2 units when you are above target. So if you set the goal of 100, so I make them decide to add 2 units every week if they get results of more than 100 every week. That is just an example. Some would do 4, 6, or 8, but I would recommend for you to just start at a low dose and increase slowly. Why is it important for us to talk about the titration period? What is the clinical importance of this titration period? So let us look at the several real world data showing us the importance of the titration period. So this real world data have shown that if you do not achieve HbA1c of less than 7% during the initial 3 months, it was associated with an increased risk of achieving glycemic targets at 2 years. So if you don't achieve it early on, the likelihood of achieving your glycemic target in 2 years is not achieved. And that many previously insulin naive people with diabetes discontinue insulin shortly after initiation. So 41% in the first month, 62% in the first 3 months, and 82% in the first year, especially if they are not achieving control. They keep on injecting and they see it's not doing any good, they're not benefiting for it, probably why most of them will discontinue insulin. So in people with type 2 diabetes with inadequate HbA1c control while receiving basal insulin treatment, discontinuation of basal insulin was at 32.1%. And hypoglycemia during the first 3 months of your insulin therapy was also seen to be strongly associated with longer term risks of these events between 3 months and 2 years. So, pag nagkakaroon na ng hypo, first 3 months pa lang, probability is there will also be more hypoglycemia even after this initiation and titration period. So it's very important that we initiate and titrate without hypoglycemia. And a retrospective study also have shown that those who experience hypoglycemia within 6 months of initiating basal insulin were more probably to discontinue therapy within the first 12 months of treatment compared to those who did not. So this is understandable. Of course, if it's your first time to inject and you are new to insulin and you are experiencing lots of hypoglycemia, they will be scared, and this will of course be correlated to eventual discontinuation of the insulin treatment. So this is a randomized controlled trial, the BRIGHT, which showed the importance of the titration period. And here, they have shown that the incidence of anytime hypoglycemia within the maintenance period was lower for individuals who did not experience hypoglycemia in the first 12 weeks. So again, reiterating the importance of titration and avoiding hypoglycemia at the onset of insulin treatment. And that a higher risk of hypoglycemia during titration was associated with continued higher risk of non-severe and severe hypoglycemia later on for up to 6 months. So the importance of titration period, these are the points to consider. Okay, so prompt titration is important for people with type 2 diabetes who are initiated on basal insulin therapy. However, early glycemic control will promote improved glycemic outcomes in the longer term and a fewer vascular complications. So after initiating, it is important to titrate because this is correlated with an outcome which is fewer in vascular complications among patients with type 2 diabetes who have achieved early glycemic control. And in the early stages of treatment, along with the pursuing, we want to achieve glycemic control, it is also important to minimize the risk of hypoglycemia, especially in the initial titration of your dose, because this will reduce hypoglycemia in the long term and reduce the risk of hypoglycemia, morbidity, and mortality. And also, it is associated with a reduction in the discontinuation of your basal insulin treatment. So, we now go to looking at the benefits of this newer or can this newer basal insulin analogs assist with insulin titration and treatment adherence. So we know we have a lot of insulin available in the market, and for basal insulin, you can actually use your old human NPH, you can use your glargine 100 or the newer basal insulin analog like your U300. So let us look at the comparison between the second generation versus the first generation basal insulin analog in this data. So the second generation basal insulin like your glargine 300 or your insulin degludec have been shown to have a more prolonged duration of action. So they have a flatter pharmacokinetics, pharmacodynamic profile, and a lower risk of hypoglycemia compared with the first generation. This is supported by a lot of trials. And also, it is given once a day, and this will help alleviate the treatment burden that we have mentioned a while ago in people otherwise requiring more frequent dosing with the older intermediate acting insulin like your NPH or the first generation basal insulin like your glargine 100 or insulin detemir, which some of them would need a twice a day injection. Also, the second generation basal insulin analog, like your glargine 300, have a lower risk of hypoglycemia, and this is observed in many clinical trials. And this will also alleviate the fear of hypoglycemia during initiation or titration for our patients and for us healthcare providers. So this could help improve patient adherence, and although there are no studies that have directly examined this relationship. Now, let us look at the different titration algorithms used in various studies. No? May +2, +1, +4, +3. But I suggest if you are new in the insulin titration, then you start slow and you go slow. +2 for me is a very practical dose to remember and to titrate your patients on basal insulin. So let us look at the different evidences from the randomized controlled trials. So edition 1 to 3 is a study done comparing the new glargine 300 versus the glargine 100. So here it has been shown that the proportion of patients reaching their target HbA1c or fasting plasma glucose at 6 months was actually similar between the two treatment groups. But you must remember, these trials were done to they both have a target range to achieve. No, so more important here is that the incidence of the nocturnal confirmed hypoglycemia was significantly lower with this newer insulin glargine 300 versus glargine 100, and that the rate of anytime hypoglycemia was also significantly lower with the glargine 300. What about the BEGIN? BEGIN is a trial done to compare glargine 100 and IDEG, insulin degludec, which also showed similar glycemic control with lower risk of hypoglycemia. And the BRIGHT trial is insulin glargine 300 and insulin degludec. So this is both a new generation insulin. And this data have shown that they have similar HbA1c reduction over a period of 24 weeks and a comparable incidence of hypoglycemia during the overall 24-week study. However, there was a lower incidence and rates of anytime confirmed hypoglycemia and lower rates of nocturnal confirmed hypoglycemia during the titration period with the insulin glargine. So overall, the same, but with regards to the time when the patients were being titrated, there was lower incidence of hypoglycemia, both confirmed, nocturnal, in the insulin glargine 300 versus IDEG aspart, or insulin degludec, I'm sorry. So these are data from the real world studies. Dun is a study done on type 2 diabetic patients who initiated or switched basal insulin therapy, and they have been shown to have achieved their HbA1c targets by 28 and 27% respectively, and that the failure to achieve these targets could have been because of insulin insufficient dose titration. What about the DELIVER? DELIVER is a study comparing glargine 300 versus IDEG insulin, and it has also been shown to have similar HbA1c reductions without significant difference in terms of hypoglycemia. The confirm is glargine 300 versus IDEG aspart. Again, here they have shown greater HbA1c reduction with IDEG than glargine 300. And also the patients experiencing hypoglycemia was also significantly lower and fewer with IDEG than glargine 300. The lightning is a data on glargine 100 versus insulin detemir, and here the rates of hypoglycemia with glargine 300 was significantly lower than glargine 100 or insulin detemir among insulin-naive individuals, but were not significantly lower with versus IDEG insulin. So let us talk about self-titration and patient empowerment. So patient empowerment has been shown to be a very good tool to achieve HbA1c control. In fact, several trials have compared doing self versus physician-managed titration, no, using simple paper-based titration algorithms. So they look at when we allow our patients to titrate their dose versus we make them come to our clinic and we do the titration for them. So several trials have shown that self-titration in fact did not increase the risk of hypoglycemia and was still effective in achieving glycemic control. Self-titration also have been shown to provide similar or even better patient satisfaction compared with physician-managed titration. So this data have shown the benefits of allowing our patients to self-titrate, especially in this time of pandemic when we cannot see them regularly, when seeing us is not easy. So at onset, when I do insulin initiation, I already empower my patients. We teach them how to self-titrate And this is proven to be effective, as you can see in this data, that self versus physician management, where patients are empowered, have shown even better results. And that the use of digital education tools, no, titration support devices, or providing them simple titration algorithm will facilitate patients to self-titrate their basal insulin. These are the summary of the different randomized controlled trials comparing self-management versus physician-led management of insulin titration. Okay, so the Take Control, Atlantus, Atlas, Innovate, and Automatics. So as you can see, it was done in the different parts of the world. I want you to look closely at Atlantus because it was done in Asia and as well at Atlas. So here, the study drug was Glargine 300 for Take Control, Glargine 100 for Atlantus and Atlas, and Innovate, and Glargine 300 for Automatic. So all this made use of the paper-based titration algorithm. Now, meaning sinusulat yung result and then they will adjust their dose based on the agreed increment and agreed level of fasting plasma glucose wherein they need to increase the dose. So let us look at the result. So as you can see, for Take Control, it was shown that there was a significantly greater HbA1c reduction achieved with the self-managed versus physician-managed titration. Same with the Atlantus and Atlas, no? There was a significant greater HbA1c reduction achieved with the self versus physician-led. And the Innovate showed actually similar HbA1c reduction and the Automatics. But in Automatics, there was a numerically greater achievement of the fasting plasma glucose without severe hypoglycemia versus the self. So with regards to hypoglycemia, as you can see, generally, it showed a similar incidence of hypoglycemia in the Take Control, in the Atlas. As you can see, similar incidence of severe hypoglycemia, but though greater incidence of symptomatic hypoglycemia and nocturnal hypoglycemia with the self versus the physician-managed titration. So personally, because of this finding in the Atlas, I do not make them adjust the dose to like really below the target, no? So which means for depending on your patient population, most of my patients I make them adjust only up to a level of 110. Below that, I am the one to decide if there is a need to adjust the dose, or maybe I can just adjust their diet, make them exercise rather than increasing the insulin dose to avoid hypoglycemia. And this is data showing insulin titration in special population. I want you to look at the senior data wherein Glargine 300 was compared to Glargine 100 among patients aged more than 65 years old and with a subgroup age more than 75. So here it has been shown that there was a lower event rates of hypoglycemia observed excuse me, with Glargine 300 versus the Glargine 100. And the Take Control here, comparing self versus physician-managed titration of Glargine 300 in older individual versus those who are below 65. And it showed that the incidence rate of hypoglycemia, HbA1c, and self-monitoring plasma glucose reduction were actually similar between age groups. And the proportion of those achieving the self-monitoring plasma glucose target without confirmed or severe hypoglycemia were higher in the older age group. So the insulin titration in the special population seen in the post hoc analysis of the BRIGHT study comparing glargine 300 versus insulin degludec showed that glargine 300 provided similar HbA1c reduction versus IDEG 100 in insulin-naive older people with type 2 diabetes, and a greater reduction versus IDEG 100 in those aged more than 70 with no increased risk for hypoglycemia. And that the simple titration algorithm used in the BRIGHT, along with the more stringent fasting self-monitoring plasma glucose titration target, which was 80 to 100, was effective in this older population without increasing the risk of hypoglycemia. So, as you can see, they targeted a level of 80 to 100, and these are population of patients more than 65, and yet did not increase the risk of hypoglycemia. So this is with the use of glargine 300 versus IDEG. So in conclusion, I have showed you that the initial period of insulin initiation and titration is a critical time for successful glycemic target achievement, especially in the long term. And that despite the well-advanced benefit of early tight glycemic control, there are still a number of barriers at the patient, the physician, and the healthcare system to initiate, intensify, and up-titrate basal insulin. And we have also showed that self-management can also be improved through implementation of a simple and easy titration algorithm, either daily or weekly, which have been proven to result in glycemic efficacy while helping to minimize hypoglycemic risk. So there is actually no evidence that the second generation basal insulin analogs improved treatment adherence compared with first generation basal insulin analogs, but we have shown several data of less hypoglycemia and fewer injection with the use of the second generation basal insulin analogs. And helping our patients to effectively self-manage their own diabetes, we can teach them how to self-titrate, have shown to provide similar or even greater reduction in HbA1c with a comparable safety profile to the physician managed care. So, and this is often accompanied in improvements in our patients' treatment satisfaction, perceived self-management efficacy, and eventually reduce diabetes-related distress. And consequently, empowering our patients to self-manage their diabetes may help alleviate many of the patient-related barriers to insulin therapy and thus may improve therapy adherence. But however, fear of hypoglycemia is a major barrier that leads to our fear to initiate insulin and their fear also by the patients and their caretakers, such that if we reduce the risk of hypoglycemia overall, particularly during the initiation titration period, when most of this insulin dose change will occur, will help in dispelling this fear of hypoglycemia. And using second generation basal insulin analogs like your glargine 300 may potentially help to improve treatment adherence and long-term glycemic outcome when compared to the first generation basal insulin analogs. So with that, I would like to thank you all for your kind